Lisa Chu couldn't make it today, but stepping right in is Neha Shah, our very own from CDC, but here at the state and part of the MDR team, and I know you guys all know her, and she's going to be joined by Gwen. Oops, Gwen, let me get your last name right. Alcazar, yeah. So Gwen is a public health nurse here in Alameda, and she's been doing TB for 15 plus years, and they're going to talk about a really important piece of bedaquiline. What does it mean now that we've got cases under our belt to actually have to case manage a bedaquiline case? So come on up. I think, Neha, you're starting and Gwen's going to join you. Yes.
I will do my best to do Lisa proud. She gave me her notes, so if I'm reading a little bit, it's because I've had a whole 10 minutes to prepare. Okay, so bedaquiline, and Gwen is going to come join me after I do the first half of this as well. Luckily, Bob went through a lot of this, which saves me the embarrassment of how to pronounce the diaroquinolone as Lisa would call it, the Dairy Queen drug. But bedaquiline is one of the first new drugs that we've had in about 40 years, which is incredibly exciting because we haven't had anything for a long time. But it's for those people who've used it, it's also really incredibly expensive. It's a selective mycobacterial ATPase synthase inhibitor, if anybody really wants to know the mechanism. There was a randomized trial that Bob went over that looked at the effect of bedaquiline at culture conversion for 2 months, and it showed that it was had better outcomes at 2-month culture conversion than a regular conventional MDR regimen. However, as noted, there was an increase in mortality. It's really unclear what that was due to. Most people seem to think it probably wasn't due to the bedaquiline, but nevertheless, that does exist. It was approved by the FDA with this caveat. Lisa has it in quotes because that's what the approval says. It's supposed to be used for patients with pulmonary TB when an effective regimen cannot otherwise be provided. We have used it in other not so dire circumstances, but that's technically what the FDA label says. So Lisa wanted me to remind you that today we're going over the practical aspects of how to use bedaquiline, how to get it, how to case manage, not necessarily the clinical parameters of it. She did write in here, if you have clinical questions, call the MDR consult team, which is myself, and Kristen and Gisela, but that is not the point of this talk. So just some general overviews, how to use bedaquiline. For the first 2 weeks, it is 400 milligrams daily, and then weeks 3 to 24, it's 200 milligrams 3 times a week, and then you're not supposed to use it thereafter as was originally looked at by the FDA. However, we have used it for longer periods of time across the U.S. People have used it longer when you've gone to the point where you don't have any other medications and you have 18 months of therapy to get through. People have done a second round of bedaquiline, or close to a second round of bedaquiline. The thing to keep in mind, though, is that bedaquiline has a very long half-life, about 4 to 5 months. So you want to stop the bedaquiline about 6 months before you stop all of your other medications so that you don't have bedaquiline hanging out by itself and potentially causing drug resistance. It comes in 100 milligram tablets, and you want to give it with food to maximize absorption. Probably not that much food, but. Adverse reactions, there's a whole list of these, and when you're giving them with 6 other drugs, who knows if this is the bedaquiline or something else, but the most important one is really the QT prolongation, as was mentioned earlier. That's especially important when you're giving it with a bunch of other medications, such as moxifloxacin or clofazimine, that also have the potential to increase your QT syndrome. What we suggest, and what's written in the FDA guidelines in terms of monitoring, is that you get a baseline EKG, and then you again do it at 2, 12, and 24 weeks of treatment. There's a T missing at the end of that, sorry. If your patients are on other QT prolonging medications, such as the fluoroquinolones, clofazimine, then you may want to get them more frequently. And then you also want to check your serum electrolytes and other clinical indicators. If the QT syndrome goes above 500, that's when you stop the medication. These are the electrolytes you want to check, the potassium, calcium, magnesium. We suggest them baseline and then monthly if you're on a medication that can prolong your QT syndrome, or as well as the injectables. Other things to monitor for hepatotoxicity, bedaquiline does have a tendency to increase LFTs, so baseline and monthly. It's likely the patient's going to be on other drugs that are increase their LFTs as well, so you'll want to draw that monthly. Luckily, there is no renal toxicity with bedaquiline, so you do not have to dose adjust for renal insufficiency. Additional monitoring, so she has this in here, and I can't tell you who will do therapeutic drug monitoring. I don't know, maybe Chuck Peliquin, do you know who do therapeutic drug monitoring for bedaquiline? No one currently. Okay, so it's written in there, but stay tuned. Bacterial monitoring, the same that you would do for everybody else. You want to do monthly sputum culture monitoring. And CDC does want you to send them a specimen so that they can do drug susceptibility testing for bedaquiline. Sorry? No, there is some discussion about checking bedaquiline levels, but it hasn't been fully fleshed out yet. Other things to let your patients know: try not to drink alcohol. Stop taking the drug if they have a change in their heartbeat or experience syncope, dizziness, vertigo, they pass out, anything like that. If they passed out, maybe they wouldn't be able to report it, but somebody hopefully at home will call 911 and immediately report symptoms of hepatotoxicity to your healthcare provider. So if you're having abdominal pain, nausea, vomiting, anything that might be concerning for hepatotoxicity. So far in California, we've had 5 patients who have received bedaquiline. I think nationally we're probably close to about a dozen, and it's been generally fairly well tolerated. We have had a few side effects. So we had one person who had serum electrolyte disturbances. They were symptomatic, tachycardic, low blood pressure, and they had a prolonged QT. They had a low potassium. They were also on an injectable, and so that individual got repleted. She got some potassium supplementation, and the symptoms improved, and that patient continued on bedaquiline. We did have one other person who had on EKG that their QT had gone above 500. They were also on quinolone and clofazimine. The quinolone was held, and the QT normalized, and they finished out their course of bedaquiline. I can't remember if they got put back on the fluoroquinolone after they finished bedaquiline. Do you know? Not yet. Obtaining bedaquiline is not, it's a little bit cumbersome. It's not hard, but it's a little cumbersome. As I mentioned, it is really expensive. It's about $30,000. It's cheaper if you have 340B pricing, but if you have 340B pricing, you have to buy the entire course at one time. You do not actually need public health approval anymore. It used to be that you needed to be approved by the state, but we know that's no longer required. What you do is you order it directly through Metro Medical. It doesn't have a wholesaler, then the drug is delivered directly to the clinician who's going to be providing it, or the public health department, whichever one you choose. She wrote out here kind of the steps to go through for how you would order bedaquiline for patients who have insurance. So there's a nice flow chart that if you are looking toward bedaquiline for a patient, let us know. We can give you all the forms that you need. We can give you the flow charts, the phone numbers, try to make it as easy as possible for you guys to be able to get it. But in general, the pharmacy or clinician will send information to Metro Medical. The Metro Medical will contact the patient's insurance to see if it'll be covered and what the copay will be. And then they feed that information back to you and they say, hey, this is how much the copay is going to be for this patient. And then the team can decide whether they want to give it to that patient or not. We have had people that have fairly high copays, and Metro Medical has been willing to cover about $7,000 of that copay. If you're public health, then you call Metro Medical. You have to set up a contract. This has been a little bit challenging for some public health departments because it's the sole provider, and some public health departments will want to put out a competitive bid. There's nobody who's going to compete on it besides these people, but that's how you can get your 340B. So that is a bit of an issue for some public health departments. Other people have been able to make the case to their higher ups and get it cleared quickly, but sometimes it's a little bit of a challenge. And then we're going to go into a case example. This is Gwen from Alameda is going to give us her patient experience.
And the big green button. All right, hi. So the case that I'm going to talk about is one of my patients I've been working with for a while now. She's a middle-aged woman. She is a newer American, though she's quite a long time, though, diabetic, and her initial symptoms were acute psychosis. She didn't really seek care herself, but when she was in care, she was found to have right upper lobe cavitary lesions on x-rays, and she was sputum smear positive. They collected cerebral sinal fluid. It was smear negative, gene expert positive, ultimately was culture negative. Oh, wrong green button. There we go. Her molecular results showed mutations consistent with INH, rifampin, and ethionamide resistance. She doesn't qualify for short course MDR therapy. And the drug susceptibility results are, as you can see, low-level INH resistance, but susceptible to the higher level, as you see. So we started her on high-dose INH, amikacin, moxifloxacin, PAS, good old PAS, and linazolid, some old and some new for her. She has had multiple side effects constantly, kind of all through the way. She had impaired renal function. We discontinued the amikacin. She had anemia and neuropathy. We discontinued the linazolid. Her neuropathy didn't get better. It got worse. We discontinued the INH. At that point, MDR team, public health, her provider, who is a private provider, discussed what do we give her next. We don't have a whole lot of options for her. She has a pretty extensive resistance pattern. We're leery about the cycloserine in this lady with a history of psychosis. Bedaquiline is a good choice. Clofazimine is a possibility. So we decided to start with the bedaquiline. It was the first time that Kaiser had ordered bedaquiline. It was a long process. The pharmacy needed a lot of help doing it. They didn't know what was going on. But it ultimately worked, and the medication was delivered directly to the doctor's office monthly. This is our little simplified drugogram for you about when she started the bedaquiline. Here we go. Do we see a pointer? Yes, better. You can see it on both now. So when she started the bedaquiline, the 400 daily, she was on PAS, moxifloxacin, and still on the high-dose INH 3 times a week. Because of that continued neuropathy, within a few days, the INH was discontinued. After a couple weeks, we went down to the 200 milligrams 3 times a week. Everything was going well. And then her insurance ran out. She had a job. Her insurance was through her work. She was on disability. She didn't fill in a piece of paper that the employer wanted, and they said, you are terminated and your insurance is no longer active. Well, we can't get bedaquiline if we don't have coverage. Our social worker, thank you, worked with her to get her on one of the covered California Kaiser plans, so she was able to continue with the same provider. It actually was active within a few days. We were very happy. But on the medication ordering side, they could not see that the coverage was active. So she was off of bedaquiline for about 3 weeks. Oops, sorry. I'm not really there yet. It was a bit of a mystery. The doctor would call to see if we could order the medication. Metro Medical, I assume, would say, no, we can't do it yet. There's no coverage. And then one week they called her and said, oh, would you like the medicine now? We don't know what happened, but it worked. It's all magic. So she started back on, and she was off for about 3 weeks. Given that there's such a long half-life, we didn't try to add anything else in right now. We were hopeful that we'd be able to get it back, and we were. And she continued on pretty well. Unfortunately, her neuropathy unstabilized, and we had to DC the moxifloxacin and added in clofazimine and Augmentin, which is what she is currently on. In fact, we're in her last week of bedaquiline right now, so that's exciting. Overall, the bedaquiline was really well tolerated. She has done really well with it. The side effects that she has had have not seemed to be related to it. Nothing got worse, timing-wise with it. She did really well with it. Of course, not so well right now, but that's the way that goes. So some of the challenges that we had were that it was a long time to get the medication started. The process was a bit mysterious. It took a little while. We eventually got it. Of course, there was an insurance gap, which meant there was a gap in treatment. The pickup was different than other TB medications. It wasn't picked up through the pharmacy. It was from the doctor's office directly, so I went to the doctor's office myself every month, pick it up, take it directly to our other pharmacy, to the pharmacy that we have a contract with to get it packed, take it to the office, or take it delivered to the patient. It was one that I, chain it to my wrist. It's that expensive medicine. Don't want to lose it from one pharmacy to the other. The nightmare, right? Losing the patient's medicine. Also, this is an unfamiliar medication for all of us. I've never worked with it before. The provider had never worked with it before. The medication workers have never seen it before. And of course, the patient had no idea what this stuff was. But we had to make sure that actually the drug guide was very, very helpful, the info sheets out of the drug guide. I copied those out, put those in the chart, in my chart, and the medication worker's chart, just so we all had it handy, just in case. So the take-home points for your everyday case management of bedaquiline: order it directly rather than through your normal processes. Remember to request those drug susceptibility tests. Regular EKG monitoring. Happily for me, it wasn't my problem. The provider was on top of that. Take it with food. That's always a bit of a problem, especially for a patient who's kind of nauseous all the time anyway. And it has such a long half-life, and we're going to stop it 6 months or so before stopping the rest of the regimen. Hopefully all will go well. Thank you.
So charting new waters for us. Any questions? Yeah, no, wait, check Pelican.
It's not a question, it's a comment.
Yeah.
We have an assay for bedaquiline. The issue is it has two metabolites that accumulate quite a bit, and you can't really get them. We have a small supply of the M2 metabolite, but we're told by the company that it's not stable, so we have to assume that it's no longer any good. We don't have the M3 metabolite. And the questions that's been posed to us on several occasions would be, well, I really have to use it with a drug that's contraindicated, but I still want to use it. Can you help us do that? And that's asking me to take on a huge amount of liability with nothing to back me up. So that's why we're not doing that assay.
All right. Chuck Pelican, University of Florida, your reference lab for a lot of our drug monitoring. Okay. Well, thank you, Gwen and Neha, for really just stepping right in, not missing a beat.